Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Nuha, Obsingani specialist at Masana'a Polyclinic, South Patina region. Today, our session is about the safe medication in pregnancy and skin diseases in pregnancy. The first part of this lecture will be about the medication that's available in primary health care, which can be used in pregnancy for skincare. And the second part is of this session will be about the common diseases of skin in pregnancy and their management. So according to the medication available in primary healthcare, as we know, this is the medication available. This is in collaboration with pharmacist Hamida. So Nystatin cream, it's available in primary healthcare, and it is B. That's mean, as we know from first lecture, B means safe medication. Salicylic acid and benzoic acid cream, B3, that's mean it is safe in a pregnancy, but they put the number 3 because it is limited. The studies that are done on this medication is limited, but can be used safely in pregnancy. Lignocaine jelly, it's safe. Mometazone furonate cream is B3, can be used also for short period, means at least 7 days, not more than 7 days. Mometazone furoate ointment is the same for short period. Fusidic acid is safe. Tetracycline, even though tetracycline capsule is contraindicated in pregnancy, as everyone knows, but as an ointment and for short period, consider B according to FDA because the absorption of this ointment is very low. Zinc oxide ointment, also consider B. Clotrimazole vaginal, whether suppositories or cream, consider safe. Meconazole oral gel, it's also considered as B. Calamine lotion, of course, it's A. Benzoyl peroxide, B, but here it's not prescribed for expatriate according to Ministry of Health. Clotrimazole tincture is B. Salicylic acid, benzoic acid ointment, B. Liquid paraffin, C, that means we can't use it in pregnancy. Glycerin of borax is also C, can't be used in pregnancy. Tendal adhesive paste can be used in pregnancy. Betamethasone ointment or cream, both of them can consider B3. And as I mentioned previously, B3 means a drug which have been taken by only limited number of pregnant women, but there's no side effect on the mother, neither on her fetus. Betamethasone scalp application is the same, B3. Clindamycin is B. Ceramide cream is B. Betamethasone salicylic acid lotion, B. Clotrimazole cream, B. Salicylic and lactic acid, also B. That means all these can be used in pregnancy safely. Clobetazole propionate ointment, C, because this kind of ointment is high potency steroid. So it's better to be avoided in pregnancy because the absorption is high, can affect on the fetus. Clobetazole butyrate cream, moderate steroid, can be used. Only we say clobetazole propionate ointment because potent steroid is high, so can't be used. Crotamidone cream is better to be avoided, group C. Silvadiazine cream, B. Permethrin cream, B. Hydrocortisone cream, B. Antifungal antisteroid, we use this too much in our field for candidiasis and pruritus vulva, considered as B. Muprisone skin ointment is B, and as you know, it's not used more than 5 days. And lastly, anti-hemorrhoid cream can be used safely. Tritinone, which is used for acne, considered is C. Hydroquinone, considered as C. Chlorhexidine and neomycin cream, B. So according to the studies, most of the medication can be used safely if you find this, except those are absorption is high can't be used for tritinon and hydroquinone can be used, and also high potent steroid is better to be avoided in pregnancy. And as you see here, there's a study done for the absorption of the ointment and the cream. If the absorption is low, can be used. If the absorption is high, it's better to be avoided. And again, just to focus on hydrocortisone or steroid hormone, steroid ointment or cream, it's better to be used for short period and not more than 7 days for acute and chronic skin disease for at least 1 month. Now we will speak about the common skin problems in a pregnancy. As you know, sometimes it's acne. We have patients pregnant with acne, and acne sometimes increases pregnancy, and sometimes candidiasis, and sometimes eczema. So again, the question will arise that many of our female patients complain about acne or sometimes unwanted hair growth and other skin problems that have only developed since they become pregnant. So the question here, are product use of these type of benign skin conditions safe to use in pregnancy? The answer in general, and after many studies, they found that with exception of hydroquinone, which has a relatively high systemic absorption rate, and tritinon, for which evidence is controversial, these products, both of these, is better to be avoided in a pregnancy. Now we have some common condition, skin disease that we have to describe the lesion. As you know, this is bullae. So if we find some patient have this disease, we will write in the notes that there is a small bullae in which the serous fluid and greater than 5 millim. A blister, bullae is less than 5 millim, blister is more than 5 millim in diameter. Eczema, everyone know, and many cases we face many patients with eczema. And if you find such lesion, it's very clear this is a plaque of psoriasis. And if you find petechia, which is visible collection of blood less than 5 millim, lignification, as you see here, thickening of the skin by chronic secretion, if you find here. Here, if you find here, this is petechia or purpura. If it is a small, it's called purpura. If larger, called ecchymosis. Physical, which is fluid, serous fluid blister, like in chicken pox. And papules, which are a rice solid lesion less than 5. If more than 5, is called nodule. So it's just, I put this slide in order to know how to describe the skin lesion. If you couldn't find the description of the lesion, simply you can mention that there's a skin lesion. And again, you find here, this is macule, in which it is a well-defined area with change of skin color. The skin feels smooth. And here you see the sign of secretion, exfoliation, which is an erosion of ulcer caused by secretion. And here is linea nigra. This is very common in pregnant women. And this is very important to know about this. This is the nipple. And this is Montgomery tubercle. Sometimes patient afraid, what is this mass? Please, again, this is normal physiological changes that happen in a pregnancy. It's happened due to hypertrophy of sebaceous gland. Please do not, just reassure the patient, this is normal physiological changes that happen in a pregnancy. So because we face many patients with Montgomery tubercles, and they are scared if it is a breast mass or other thing. So it is not infection, it's nothing, just it's hypertrophy of sebaceous gland. If there is itching, you can prescribe some ointment to reduce itching. Otherwise, it is considered normal. Now, we'll speak a little bit about physiological changes to the skin in a pregnancy. Up to 90% of women, there is increase in pigmentation, maybe linea alba or called linea nigra, as we saw here. Sometimes it's happen around the nipple and areola. There will be increased pigmentation. Sometimes also increased pigmentation around the external genitalia. Sometimes there is melasma in the face. And sometimes there's increased palmar erythema. Sometimes there's a stria gravidarum, which is a stretching sign on the abdomen. It will be stretching sign on the abdomen. Acne vulgaris means increase of acne. Sometimes Montgomery tubercle, as we prescribed here. And also there's increased number of telangiectasia and spider nevi. And of course, there's increased varicosities, which is dilated vessel in the lower leg or vulva or vagina, and sometimes increase in the hemorrhoid vein due to the pressure of the uterus, pregnant uterus. So physiological changes to the hair and nail, as you see, there's sometimes increased hirsutism, increased thicker hair, and sometimes regarding the nail, they become brittle during pregnancy and show faster growth. And dystrophic changes or pigmentation may occur. And after the pregnancy, especially first 3 to 6 months, there is increased risk of hair shedding. That's why many women, they come and ask us if there's any medication to stop hair shedding. Just we reassure the pregnant, the postnatal women that this is sometimes happen normal in the first 3 to 6 months. But of course, we prescribe for hair FeeFol. And recovery can happen by 9 to 12 months. So now we'll speak about the eczema. You find sometimes there's many pregnant women, they have eczema. So sometimes the most important thing is we must know what are the risk factor that increase to this eczema, because most of these women has some allergy. So there's some factor that increase exacerbation factor. And we'll ask for skin hydration by giving some emollient, and recognition and treatment of superimposed infection, because sometimes they are lead to itching and secretion and super added bacterial infection. So again, how is the management? As we say, for any skin disease, any skin lesion in a pregnant woman, please start with emollient. So many may ask, what are the emollient? Emollient, it is combination of creams or ointments like bath oil or emollient soap substitute. CeraVe, this is very common all over the world. It's very effective as emollient. It's available in private, not in the Ministry of Health. You can also use Rene, Ripilene, Vaseline also. It can be prescribed as an emollient. It's available even over the counter. KY jelly, it's available here in Ministry of Health. Sometimes we prescribe KY jelly for dry vagina, especially in menopause, because it has no any hormonal, so it is safe. And also palm consider as emollient. So always start with emollient first. If there's no improvement, we can start with corticosteroid. And as I mentioned in the beginning, for acute exacerbation, 1 week. For chronic, we can use 4 to 6 weeks. And as you remember, for corticosteroid, we use the low potent. We can use hydrocortisone 1%. Betamethasone also is moderate, but as if you remember, for the high potent, we will not use the high potent for pregnant women. As I will show you again here, the high potent is like clobetasol propionate ointment. This is better to be avoided in pregnancy. Sometimes we use this for postmenopausal women, for vulval disease. Later we'll do a lecture about vulval disease. Is very effective, but this is contraindicated in pregnancy because it is potent steroid. Otherwise, we can use the hydrocortisone cream or betamethasone cream for skin itching, but mostly we use hydrocortisone 1%. So the third line of management of eczema is oral antihistamine. As you know, chloramphenormin maleate, which is known as Elervine, can be used. Sometimes you can use loratadine, what's available. All oral antihistamines are safe in pregnancy, and you can use it in all trimesters. So in general, eczema get worse in pregnancy. Emollient is the first line. Topical corticosteroid use safe. Topical tacrolimus is safe. But as a primary health care, as gynecologist, as GB, our level is only these three things. More than this, we will refer to dermatologists because most of skin disease is multidisciplinary team management. That's mean with dermatologist specialists. Just to have an idea, UVA, ultraviolet A, and UVB is safe in pregnancy, but BUVA is considered contraindicated. Means P is zoraline, which is contraindicated in pregnancy. Cyclosporine, azithromycin, just to have an idea, if you have any patient pregnant and taking cyclosporine and azithromycin, it's safe in pregnancy. Prednisolone also can be used in pregnancy, considered safe. Sometimes due to the eczema, the patient will secrash. So sometimes there is superadded infection. Sometimes there is herpes simplex infection. So if you need to prescribe a cyclophosphamide, it is safe also in pregnancy, can be prescribed. We'll come to the second disease in skin disease, psoriasis. As you know, psoriasis, many of you know what is psoriasis, and they saw many patients with psoriasis. As you know, there are three types, either plaque psoriasis or cutate psoriasis or pustular psoriasis. If you see here, it's like pus. However, psoriasis is also the treatment is with dermatologist, but suppose the patient come to you at night, or there is, or the patient has late appointment with dermatologist. So it's better to, again, to start treatment because you must know something about everything and to start the treatment. But to have an idea about psoriasis, most of the psoriasis get better in pregnancy in around 60% of women. Although 15% find their disease worsen. Postpartum flare is common. So in pregnancy, it's improved, but postpartum will be flare up again, especially in first 4 months post-delivery. In general, psoriasis has no effect on pregnancy. So if I have any patient pregnant and they have psoriasis, I will not afraid from psoriasis about the fetus or the pregnancy. Also, again and again, the emollient is the first line of management. In a pregnant, topical corticosteroid, again, safe option. Also safe sometimes, but in general, they say here safe after first trimester, but in general, according to the many studies, corticosteroid ointment considered safe, and even there are sometimes prescribed prednisolone from first trimester of a pregnancy. And again, UVB is safe, but PUVA is contraindicated in pregnancy. And again, cyclosporine, this is not by prescribed only by dermatologists, but it can be used in pregnancy. So if pregnant woman has psoriasis and she is taking cyclosporine, this is safe in pregnancy, just to have an idea. Biological agent, also it is safe, but it's better to be stopped at 28 weeks from third trimester because will reduce the neonatal immunosuppression. So if patient on biological agent that's prescribed by dermatologist, we just will advise her to stop it at 28 and inform her that to not give live vaccine to the baby, like BCG, MMRI, because already there will be decreasing neonatal immunosuppression in first 6 months. What about acne? Many patients, they have acne. So just we want to have an idea what to do if pregnant women came to us with acne. So here we just say acne usually improves in pregnancy because of estrogen, and the progesterone will be increased in pregnancy. However, it is worsened in third trimester because increase sebaceous gland. And if you remember, we say increase sebaceous gland sometimes will lead to Montgomery tubercle in the areola, the breast of the pregnant woman, which consider as normal. Acne in general has no effect on a pregnancy. However, some women with acne have difficulty in conceiving due to underlying hyperandrogenism. That means acne, as you know, sometimes it's increased in a patient with non-case of polycystic disease. And you know, polycystic disease, sometimes they have delay to get pregnant. However, this is not our subject because we want to speak about the acne in a pregnancy. The treatment in general is, again, you can prescribe benzoyl peroxide, topical antibiotic, azelaic acid, all these three, benzoyl peroxide, topical antibiotic, azelaic acid, considered to be safe in pregnancy. Topical salicylic acid and topical retinoid should be avoided because of safety concern. However, the last update, they say topical salicylic also can be used, but the retinoid should be avoided as much as avoided in pregnancy. Regarding systemic antibiotic, oral erythromycin is safe, but of course, oral tetracycline should be avoided. And of course, hormonal should be, and retinoid again should be avoided. Women who conceive while taking retinoid within 1 month of taking retinoid, it's better to over termination because retinoid has a side effect, teratogenic effect on the fetus of pregnant women. So in general, if patient comes to you with acne and she is pregnant, always we can, of course, you will advise her for hygiene, avoid some irritant material to the skin of the face. You can start with topical benzoyl peroxide. You can advise her to use it 1 or twice daily as a first-line treatment. Topical antibiotic, topical, as clindamycin, erythromycin. Salicylic acid, they say, is best avoided in pregnancy and breastfeeding due to risk of salicylic poisoning in the fetus. However, if you want to use it a little in pregnancy, it's okay, but it's better to be avoided. Azelaic acid safe, topical retinoid should be avoided because of the teratogenicity. Erythromycin capsule is safe if you want to prescribe oral antibiotic. Again, the last subject will speak about dermatosis of pregnancy. We have 3 dermatosis of pregnancy: atopic eruption, polymorphic eruption. If you see here, is spare the area around the umbilicus, and vermifugoid gestation. If you find here, is like pulli. There's pulli. So again, atopic eruption, as we mentioned here, sometimes there's personal or family history of atopy. Can happen any point in a pregnancy, but mostly before 3rd trimester. Happen in anywhere in the body, but commonly face, neck, chest, and flexor surfaces. And there are 2 types, either it's coming as eczematous lesion, papule and vesicle. And we saw the picture of the eczema and papule and vesicle, or disseminated erythematous papule. For investigation, no need for any investigation here. The treatment, again, emollient, topical antipruritus, like hydrocortisone 1%, topical corticosteroid, antihistamine, UV light. So this is atopic. mostly eruption, mostly there's family history of allergy or personal history of allergy. Can happen anywhere, mostly in the flexor surface. And you find here sometimes it's appear as eczematous or papule. So the treatment here, as we say, first thing is emollient and the topical antipruritus or topical corticosteroid. The second thing is polymorphic eruption. As we say here, is spare the umbilical area, but mostly it's happened in a primary gravity or a twin, or there's increased rapid gain. It's happened late in the second trimester to immediate postpartum period. Here happened before third trimester, but here after the second trimester because there is increase in the size of pregnant uterus. If you find here, it's mostly on the abdomen and sparing umbilical region, and can happen in, can spread to the trunk, but spare palm and sole and face. Here, many in the face and in the flexor surface of the hand. For polymorphic eruption, sometimes appear as papule, plaque, or target lesion, physical and small pulli. Sometimes we are not doing any investigation, but if you want to have an idea, it's by histology. The treatment is again the same, but we can add oral prednisolone if severe itching. So again, emollient, topical antipruritic, topical corticosteroid, antihistamine. The pemphigoid gestation, this is very high-risk pregnant women because this is autoimmune, sometimes associated with the Krebs disease. Can happen after second trimester, like polymorphic eruption, and begin in periumbilical area, spread anywhere but sperm, mucosa. And the typical will be pulli and target lesion, okay, and papule and the plaques. If you want, this is not necessary. Also, the histology will be prepullus face, upper and middle derms oedema. The treatment again, emollient, topical antipruritic, topical corticosteroid, antihistamine, oral prednisolone. Sometimes we use here azithromycin, cyclosporine, and plasmapheresis. So this is benign, nothing. Just give, as any dermatology or any skin lesion in pregnant, start with emollient, antipruritic medication, and corticosteroid ointment or cream. For polymorph eruption, it's spare the umbilicus, but pemphigoid gestation, this is dangerous. Here can affect on the baby. So here we must deliver the baby sometime earlier and need to do follow up more closely for this patient. Again, there is some important disease in a pregnancy. I would like you all to know about it. It's called intrahepatic cholestasis of pregnancy. Many women here, they will come to us after the second trimester, beginning of third trimester, around 24, 26, 28. They don't have rash, okay, but they have very severe itching, especially in the palm and of the hand and mostly at the night. So they have generalized itching at night. There's no rash. So please do liver function test. You will find elevated AST, ALT, transaminases, and bile acid will be elevated. If it is elevated, please prescribe the same medication, emollient. You can start also giving chloramphenicol malate tablet, but please refer to a secondary hospital because this is need fetal monitoring and sometimes need yearly induction of labor after 37 because there's increased risk of perinatal morbidity. Many cases may end with a stillbirth, so any woman has severe itching at palm and hand and there is no rash, after 24 weeks in the end of second trimester or first or beginning of third trimester, do LFT, you find elevated AST, ALT, refer to its specialty to the secondary hospital because need fetal monitoring. Some cases, there is increase what is called alkaline phosphatase. Alkaline phosphatase, it is normal increase in pregnancy, so no problem. But increase AST, ALT, we must do further investigation because AST and ALT must be not increase in pregnancy. Alkaline phosphatase, normal increase in pregnancy. So this is a little short, no need for you to know, just we have to know if the patient present with pruritus without rash, do liver function test and bile acid. If it is increased, refer to secondary hospital because there's increased risk of stillbirth. And these are the references about the dermatological problem in pregnancy. It's just, it's just in general, any dermatology, we can, if it is normal physiology, need just reassurance, give emollient, give antipruritic, whether it's cream or tablet like chloramphenicol malate or loratadine. And if severe, if acne or if psoriasis, of course, it's multidisciplinary team with dermatologists. Otherwise, no need any further thing from our side. Only we give emollient, as I say, and antipruritic cream or ointment or tablet, and we'll describe the lesion as we say. If you couldn't find the word to describe the lesions, just write skin lesion. And that's all regarding the dermatology problem in pregnancy. These are the references if you want to know more about it. And I wish this will benefit you in your practical management of pregnant women with skin lesion. Thank you very much.